Good afternoon, and I know it's late, but I think you'll find this an interesting subject. I hope many of you in the audience who use intravenous cable filters will take note of this and maybe have some discussion at the end. You have no disclosures relevant to this presentation. The IVC filters are designed to prevent pulmonary embolism, or at least reduce the serious ones. There are two types, permanent and retrievable. There's multiple indications for using them. And as you see on this slide, there are multiple types available for use. I'm not going to dwell on the types, but basically talk a little bit about the indications. There are two absolute indications. One is an active thrombophlebitis in a patient with an extremity or pelvic thrombophlebitis with a contraindication to systemic anticoagulation. The other is a documented pulmonary embolism despite systemic anticoagulation. There are a myriad of relative indications for pulmonary embolism, and how frequently for intravenous cable filter, and how liberal you are in the application of these devices depends a little bit on what country you live in. They're very commonly put in the United States because they're reimbursed well, and they're put in for a wide variety of reasons, many of which I don't agree with, but certainly some of them are prior history of pulmonary embolus and low extremity DVT, contraindications to DVT prophylaxis in patients with prolonged periods of immobilization, neurologic injury with paralysis, people with multiple trauma, and sometimes people with hypercoagulable states. There are probably many more that I could add to this list. The case I'm going to present to you is a 29-year-old man who was involved in multi-system trauma, treated at an outside hospital. And because he had multiple trauma, he had an IVC filter placed, which is common in our institution and in many institutions in the United States when people come in who are on a ventilator for a prolonged period of time and have had multiple trauma. The patient was transferred to a rehabilitation center. The filter was not removed. We almost always put retrievable filters in people now, and this one was not removed. 12 months later, he presented back at our institution with 3 days history of worsening abdominal and back pain. He had some guaiac positive stools and a very minor anemia. He had upper GI endoscopy done, as you can see, and if you look at this, I think it points out, I got it here. You look on the thing, these are the ampulla. There's one of the tines of the IVC filter, and there's another one. These are protruding into the lumen of the duodenum. They've come through the wall of the vena cava and are into the lumen of the duodenum. And we're actually the site of where he was having his GI bleeding. Had a CT scan done. You can see that's the crown of the retrievable filter, and it's embedded in the wall of the vena cava. You look as it begins to materialize along the CT scan. You can see that multiple tines are outside the wall of the cava. I think there's one. There was another up here. Here's another one outside the wall of the vena cava. There's two more over there. If you look on the lateral view, you can see very easily the one protruding into the duodenum. There are actually two are protruding in. And again, there's another one going to the back. One's protruding actually into the anterior spinal ligament posteriorly. And here's just a better view of this. Two tines going outside the cava, very easily demonstrated. So is this a significant problem? I'm asking the audience. Is this a problem? See these tines sticking outside the vena cava and in the bowel? Anybody concerned about that? Okay. Well, we thought it was. And the options for management are non-operative repair, just observe him. His pain persisted while he was in the hospital, but it was easily controllable. Open surgical repair, endovascular filter removal, either a standard snare and sheath removal or laser assisted. This filter had been in, though it was a retrievable filter, it had been in for a year. And we really did not think it was retrievable. And additionally, if you look at that CT scan, the crown where you would retrieve it was stuck in the wall of the cava. And that makes it very, very difficult to retrieve it using standard techniques. There is a laser-assisted means of doing it, but that too is difficult when one's been in for over a year or more. So we chose open surgical repair because this fellow did have these points sticking into his GI tract. Did a midline laparotomy and medial visceral rotation. You can see what was done. We basically exposed the filter. It was exposed to the duodenum. You can see on this slide there are some tines of the filter. I hope they show there's one right there, and there was another right there. And here's another. You can see it sticking right into the bowel right there, another down here. The filter hook was found inside. We actually included the vena cava superior above the cava with the filter and below it, opened the cava and attempted to remove the filter from the cava. I will tell you that it was extremely difficult to do, and the crown of the filter, which is where you would try to engage it with the removal hook, was angled, slanted into the wall of the cava, and I don't think it could have been removed endovascularly. There was fibrous constriction of the vena cava around the area, obviously from chronic inflammatory reaction, and the metallic barbs were really tough to cut. We had to get orthopedic pin cutting shears in there to cut them off in order to get the thing out without tearing the bowel substantially. So after we did this case, the patient did well and ultimately went home. But there's some general concerns that crossed our mind about this. Is wonder, one, how common it is. Two, is it an issue that we really need to worry about? And if you go onto the Google IVC filter in the United States, what you get are 3 or 4 law firms come up first before anything else, and they're recommending that you can maybe be entitled to compensation if you've had an IVC filter placed for reasons. The FDA recommendation in 2010 was if you have an IVC filter placed, it should be removed as soon as possible when it is no longer needed for protection from a pulmonary embolus. So we looked at our experience between 2010 and 2011. There were 323 filters placed in our institution. We're a level 1 trauma center and a tertiary care referral base for an area, a very large area that services probably 5 to 6 million people across the mid part of the state of Texas. 10 hospitals feed into us and 65 clinics. And so if you look at this referral, there were 76% were retrievable filters, 8.3%, only 8.3% were removed. 1 failed removal. And if you look at the pie-shaped chart, you see 60 had an incidental CT scan performed so we could see whether any other of these were sticking outside the vena cava. 23% of those who had a CT scan had demonstrated IVC filter perforations. 23% of the 60 who had CT scans done had perforations of the cava from the tines of the filter. That's a 5.4% known overall perforation rate. And it's not related to any particular type of filter. The optes and the trapeze are a little bit less, but almost all the ones that were put in had some degree of perforation identified on a CT scan. I'm going to show you a few of these just to show you that we're not just making this up. Here's another case. This is not the one presented today. Tines are both outside the filter. Here's another one with a tine out into the aortic wall. This is the aorta. It's in the aortic wall. Here's one with a small aneurysm, and there's a tine going into the aneurysm on its anterior wall. There's another one, same patient. The tine is actually penetrating into the aneurysm. So the question is, what do you do about this and how big a problem is it? Well, we've only had to remove one, and that was in a patient who was symptomatic. I think the FDA's recommendation to remove IVC filters as soon as possible to prevent long-term complications is quite appropriate. I think one of the big problems is that these are put in patients, many of them for multiple trauma or other reasons, that go to continuing care hospitals that are lost to follow-up, and in the end, unfortunately, they don't come back to have their filter removed in a timely manner, and when somebody does recognize it's been in there too long and they're too difficult to remove. I think you should consider open surgical filter explant in symptomatic patients, and filter design may influence the perforation rate, although we found it in all the filters we implant. I truly believe the magnitude of this problem is seriously underappreciated. And I think we're looking at it now at all the filters we put in, and certainly there's a big push in our institution to remove all the temporary filters that we place. Thank you.